Yeah, okay.
Yes.
All right. I will be talking a little bit fast because I have to leave the seminar for about half an hour, from about 10 minutes to 3, so I will be a bit quick. So I would like to talk about innovation and more on system innovation and social innovation. And why this choice? If we deal with long-term care issues, if we deal with elderly care issues, most of the care that is being provided is provided by informal carers in society. So it's about 70–80% is internationally regarded as care that is provided by non-professional carers. So if we have to find a solution for what is happening in long-term care and healthcare, we have to look at society, but because probably the solution lies there. I would like to share with you 3 paradigm shifts that are ongoing, at least in the Netherlands, but probably across our borders. It's on views on health, on quality and outcomes, on healthcare, social care, long-term care in their societal context. I'll say a few words on our national quality framework for nursing homes in particular, and I'll give you a number of examples of social innovations in elderly care, which are sort of in line with the statement that the solution should be more in changing paradigms and in engaging the community than in just building more nursing homes or hospitals. First of all, our view on health is changing. The traditional view on what health is all about, we often use the definitions of WHO dating from 1948, which defines health as a state of complete physical, mental, social well-being, and not merely the absence of disease or infirmity. And if you take this definition literally, in fact, hardly anyone is healthy, because all of us are suffering from some kind of disorder, discomfort, or whatever. And if we would like to remove all these problems, we get into a very medicalized society, and that's not really what we would like to know. We have what we like to have. We have many long-term conditions, and you have to live with it. And in the Netherlands at this moment, a new view on health is very popular. It has been formulated by Machteld Huber, a physician, who states, well, health is more the ability to adapt and to self-manage in the face of social, physical, and emotional challenges, which means that we have to focus on resilience of people and to adapt and to help them adapt to this new situation of some infirmity or of frailty. This does not mean that you don't have to treat people or that you cannot cure diseases, but you cannot solve all the problems by healthcare, and you have to facilitate people in living their lives, sometimes in the face of what are the challenges in their lives. And about half of the Dutch municipalities have adopted this concept in their local policies, health policies, in order to improve their societal values, their societal development, and to innovate society in a way that is much more in line with this concept of health. The second, and what you see if you look at this healthcare paradigm, it is not adopted by everyone in the same idea. Machteld Huber said, well, health is about your bodily functions. You can read it on the below line. It's about health functions and perception. It's about spiritual needs. It's about quality of life, social, societal participation, and daily functioning. This is what citizens regard as living a healthy life, when the scores on these 6 dimensions are well. However, if you look at what, for instance, that's the pink line, the policymakers, how they think about what health is, they don't consider, for instance, the spiritual dimension as an aspect of health. They're only and also societal participation is something they don't consider as health. So what we see is that the definition of health and how people see health differs across various stakeholders in society. So it's a big challenge to align all these views and to make a sort of a policy which is meeting the requirements and the needs of all citizens, professionals, but also system parties. So thinking differently about health has also its implications for the healthcare system and for the social care system. The second paradigm shift is what we see is on the view on what is quality and what are the outcomes of good quality care. The traditional view on quality is that the doctor knows best. It's a very protectionistic way of looking at quality. It's paternalistic, and a lot of this knowledge was very implicit. And we saw also great practice variation in the treatments of various professionals in healthcare, which was undesirable. Then we saw a development, which is currently pretty dominant, that we were very explicit in what kind of knowledge do you need. We have developed quality standards, we have guidelines, etc. And we had pretty uniform outcomes. We would like to have uniform outcomes. And it's a sort of reductionistic view on what quality is. It is seen as one problem has one cause and one solution. And that's not how reality looks like. And looking at the current and the new type of quality thinking that we have at this moment is that we see, well, we are in a situation that there are explicit and implicit sources of knowledge, what is described as evidence-based in the literature, but also what is in people's lives, how they live, how they operate, what their norms and values are. And we see that when we are dealing with quality, we see that there can be pluriform outcomes. So for various people, there can be various outcomes depending on their context in which they live and the values that they adhere to, what is important to them. If you have a successful operation for a broken leg, for instance, when you're young, you should be repaired so that you can run your marathon again, for instance. And when you're very old, it is nice if you can walk, and maybe if you broke your hip, for instance, it is the question whether you should repair it. So it's very context specific and very according to what the person in question needs and wants, how you look at quality and whether you've done a good job in repairing, for instance, the hip fracture. And the current thinking in our country on quality and how you should use quality is more that it should be a learning cycle where you improve your way of working and where you improve the quality of life of the person you're dealing with. And the third shift, it's a very complicated picture, and I would recommend to read it later more in detail, is in fact the context, is the society shift that we see. We come, and you look in the left-hand side, from a paternalistic system where central government says what to do and central government determines what the budgets are and what the protocols are that should be used and considers the citizens and the patients as passive recipients of care and of public solutions. And that was a picture of a few decades ago, but still we have a lot of this thinking. And when we are now in this COVID period, in this Corona period, we see that there is we see paternalistic acting states coming back again. We are seeing much central governance on how to deal with the the coronavirus. After that period, we got into a system which has been called the ego system, where people have the choice, where people behave as customers in the healthcare field and in the social care field. And we saw that there was sort of controlled competition where we organized a competition between care providers to provide the best care and the best outcomes for the best price. It's a little bit where Henk told about in this privatization movement. And we saw it in many countries in the times of the new public management. And at this moment, we see tendencies of moving towards an ecosystem. We see that the government at national level and at local level is much more connecting. It more values reciprocity between citizens, policymakers, healthcare insurers in our country, healthcare providers. Together, they should do the job. And because our society is so complex, and because the care demands are so complex and long-term, there's not one good solution for a problem. It should be developed at local level, and so we see ecosystems developing. We have hundreds of pilots and experiments in our country. Sometimes people say you suffer from pilotitis in the Netherlands, but that's in many countries. And all these pilots are there in order to develop local solutions for local problems and to develop a system with the local stakeholders, how to improve the quality of life of people. I don't say quality of care, I say quality of life. That was not an error. So it is these three paradigm shifts that are ongoing at this moment, and that determine how we look at the long-term care needs and at elderly care. As you've heard from our from our ambassador, it is a big challenge how to find enough people to provide care in the future. And we in the Netherlands are a relatively young country, but we are aging quite rapidly. So it's a big challenge how to find solutions in our society. And it is very important is how do we look at what is health, what is a good life, what's a healthy life, what do we consider as good quality, and how does it fit in a society which is changing. And this presentation is as if there were no corona crisis or whatever. So, and it will be very a big issue how we will come out of this crisis and into what direction of quality of health and of society we are moving to. And that could be an interesting debate for after the break. Anyhow, with this in mind, we had an issue 4 years ago in quality of nursing homes in our country. It were some scandals and there was a lot of criticism, and although we spend a lot of money on long-term care, there are still quality issues. And we developed a new type of quality framework of how to assess the quality of nursing homes, but for all, how can they improve and on what factors should they steer? And in fact, we said there are 8 fields on which measures have to be taken in nursing homes in order to improve the well-being of the quality of life of their clients, their patients, or their residents. First is to deliver person-centered care and support. Second is to provide well-being. Thirdly is to ensure safety. And fourth is to learn and improve the practice of care. These are the blue fields, and they are of a distinct color because that is what you do in the primary care process when you work with nurses and nurse assistants and doctors, etc. You have to focus on these fields. And we say that, well, if you look at person-centered care, for instance, that can be by definition very variable, very diverse for each person. And if you look at safety, we have a few quality indicators which are very objective and which can be measured across nursing homes. But most of the indicators that we use are very local and just for this particular nursing home. And we encourage organizations to use similar instruments in order that they can learn from each other, but they're free to choose whatever indicators they use. in the brown yellowish part of this figure, you see that the use of information is important. So if we say there are no information, very detailed information standards, you still need to use information to know what your clients, how they value your services, how many faults you have, how many pressure ulcers, etc. So the use of information is still important. How to run an efficient organization. Secondly, it's how do you use your resources? It's the lifts, it's the elevators, it's the mouth, nose masks, etc. Thirdly, it's how do you come to a good staffing ratio for the population that we have. We had a discussion whether you should have a national standard for staffing, and we chose not to choose this norm, a national norm, but we said, well, there should be sufficient staff according to the facility and according to the characteristics of the clients that you have. And at critical moments, there should be at least 2 members of staff available. And that sounds as a very vague norm. And in the beginning, there was criticism because the field, people working in the field wanted to have very concrete norms. But we said, well, I was involved in this, in developing this thing, so therefore I can say we. But we said, well, we don't use set norms because every situation is different. Think of this ecological approach. And now, after some time that people got used to it, they really appreciate, because they say, well, if you use your good senses, you know when you need 2 or more staff and when 1 staff is sufficient. And fourthly, we were focusing on leadership, governance, management. That's also something that needs to be well ensured and should be well arranged. Well, this is how we look at quality of nursing homes. And this has been a sort of a system innovation because it's encouraging not accountability, or there is still a need for accountability, but not followed by punishment if you don't meet your requirements. But it's a learning model, and it ensures that people are learning and that organizations are learning and improving. And this can be applied to nursing homes, but as I said, it's not only nursing homes where we should find the solutions. So I move on now to a number of social innovations that we see in elderly care. First, this is the Hogewijk nursing home, which has been built and designed as a sort of a small village. And people can live there, and they can be pretty much, they can suffer from dementia quite a lot, but they still are in a sort of a village-like environment, which is pretty familiar. When you see it, there's on the right top right-hand side, you see the shopping, the supermarket in this village. You see a central terrace, a meeting hall. You see a bar, etc. So the idea was, we'll make it as normal as possible, because if you suffer from dementia, it is important that you live in an environment where you can find clues for your memory, where you can recognize where you are and what you should do. It's city-like. They have also various types of groups according to their lifestyle. So people who are more city-like people are shared in group, are going together. The Goois, which is a sort of elite type of people in one of the richest part of the country, they also form groups. We have people who have a cultural background, who are an artist, for instance. They live together. People who have a sort of traditional environment in which they would like to live. So we see communities within this sort of nursing home village according to the lifestyle of people, not according to their degree of dementia or their disease, but according to their lifestyle. I move on to Humanitas, which is a nursing home that said, well, we have a number of apartments, but why should we only have older people in our apartments? So they also invited younger people and students to live in this community, in this, in fact, residential or nursing home, together with older residents. And it's one of the coolest homes in the world, I think the New York Times wrote. And the interesting thing is people like to live in mixed groups. And these young people live there. Often they're students, and they pay much less rent than what they would pay on the private market. And they are expected to provide about 10 hours volunteers work every month. And well, as you see, it's pretty cozy, and the old people like it, and for the young people, it's also very nice. It's only 10 hours a month, so they are happy to provide it for a lower rent, and they appreciate the social interaction, and that holds for both groups. A next innovation or movement which is going on, and almost half of the Dutch municipalities are following this, are implementing this, is becoming a dementia-friendly municipality. And that's a municipality where people are being taught in interaction with people with dementia, where there are services which are dementia-friendly, which are easy accessible. There is support for informal carers, for instance, in these municipalities. And so the policymakers and the civil servants are trained to interact with people with dementia. So they can get a label of being a dementia-friendly municipality. And the idea is you have to start to deal with dementia while people are still in the society. Dementia is on average about 7 years. People suffer around 7 years on average from dementia, and 1 or 2 years they stay in a nursing homes, which means that 5, 6, and sometimes even more years they live in their own original homes or dwellings. And it is important that the society can deal with it and can be receptive to them. We also see many citizens' initiatives the past 10 years in our country. So citizens have gathered together, and they said, well, let us together make an initiative to be receptive, to be friendly to people with long-term disabilities. That can be people with dementia, but it can also be mental handicaps or physical disabilities or learning disabilities. So we see across the country 600-700 citizens' initiatives. They, in the beginning, mainly in rural areas, but now also in cities. This is in Amsterdam, where they have about 20 city villages, as they call it, because their approach is, well, you can look at a city as a collection of villages of 3,000-4,000 people, a size that you can know each other. So in Amsterdam, there's about 20 city villages in which they care for each other and which they take responsibilities for each other. In the crisis of the agricultural sector, we saw a number of farmers who started green farms where people were older people with dementia, for instance, but also people with mental problems, long-term mental problems, people with mental disabilities, learning disabilities, could go to the farm, do work at the farm, take care of the animals for the garden, etc., and live a life which is sort of normal and not having artificial activities in their institute, but go into the nature and go into the field. And it was very successful. In about 10 years' time, we got more than 1,000 of them. At this moment, there's a drawback because of different funding situation, but also because of this corona situation where a number of these activities are not possible anymore. We also have Alzheimer cafes and network across the country where people meet, have social interactions, something which is music or just fun, but also information about Alzheimer's disease, how to deal with it and how to work with it, and how to live with it in particular. And it's a very light way of a light intervention and a light service, but it is very meaningful for at least a number of people. So what will the future bring? I think we should focus in the future on person-centeredness, well-being, pleasure in life, safety, these types of values, and that it is important that people are interacting with each other and come to joint decisions about what is good in their lives and what is helpful. We should focus on quality and outcomes in terms of what is the client perspective, can we see that as a leading perspective, looking at autonomy of people, looking at connectedness to other people, and purpose in life as guiding principles. And if we look at quality, it should be about learning and improving. Looking at the societal context, we should the challenge of an aging society is that large and that complex that you have to solve it at local level, at small scale level, is my conviction. And finally, I think the well-being of staff is a crucial factor in quality. If we don't take care of the quality of staff at this moment, we have already a lack of staff. It will be much larger in the future, so we have to be very take care of the staff very well. And finally, the quality of the dialogue between the person who needs care is key. So thank you very much for your attention, and I'm looking forward to the discussion, but I have to postpone it until the plenary session.
Thank you so much, Henk. A very interesting presentation, and Magnus has promised to remember all the questions from Menti. Well done. And then we will come back to you, Henk.
Yes, and now I have to leave for a moment.
But I think it's very important that you give us a framework on quality, because what do we need innovation for? It's to increase quality and lower costs. Henrik was talking about the outcome, and you were talking also about quality, as well as giving us examples of social innovation. The innovation is not only the latest pharmaceutical or robot shower, but it's also a question of social innovation. So very interesting. Welcome back later on, Henk.
Yes, see you then.
See you in a while.
Bye-bye.
Bye-bye.